Have you ever heard someone say, she thinks like an engineer or he talks like a doctor? What does that even mean? Is there really a certain way different professionals think? What does that look like for medical SLPs? Today I'm going to talk about common thought processes and patterns of a Med SLP. Just to be clear, there isn't one way of thinking for any profession. We are all unique and come with individual experiences and processes. What I'm about to cover are 3 necessary components of the Med SLP mindset to help set you and your patients up for success. Let's dive in. I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the Med SLP Collective and MedSLP Education. Number 1, go into detective mode. As clinicians who evaluate and treat, it's important to get into the detective mindset. This means asking questions, digging deeper in chart reviews, interviewing patients, and interviewing caregivers. Just like a detective, we might be given a report of symptoms, but we need to investigate what could be causing those symptoms as they relate to our scope of practice. Remember, dysphagia is just a symptom, not a diagnosis. Sometimes, our investigation work can completely alter a patient's plan of care. I have 2 examples I want to share. One that shows how deep investigation changed a patient's plan of care, and another example of how not digging deep enough led to a delay in treatment. Let's start with the story about an SLP altering a patient's plan of care because of her critical thinking. A member of the MedSLP Collective shared a case she was consulted on where the patient was diagnosed with a transient ischemic attack, or TIA, known as a mini stroke. She reviewed the patient's chart and saw that the MRI was negative and the patient's NIH score was 0, meaning no visible symptoms of stroke were present upon assessment. The SLP then completed her cranial nerve exam along with some high-functioning cognitive communication screening questions, and she noticed something. Her findings weren't congruent with the information provided by the neurologist and the rest of the medical team. It just was not adding up. She wound up speaking with the neurologist, nurse, case manager, and the director of professional services to advocate for another assessment given the impairment she was seeing during her assessments. Initially, everyone she reached out to didn't think much of it and told her the patient was fine and would be discharging that day. She persisted, however, which led to a second MRI, and a new right hemispheric stroke was discovered. Had this SLP just relied on the initial reports or didn't question the mismatch between her findings and the chart description, this patient would have been discharged without receiving appropriate care. Just as we learn from our successes, it's helpful to also learn from our mistakes as well. One SLP I know shares this story often in the hopes of others learning from her experience. When she was just starting out in the medical SLP world, she received a consult for a patient in the psych unit of the hospital she was working in. The patient was admitted for an acute onset of hallucinations and atypical behavior, which was corrected with the appropriate management of her medications. One nurse noticed the patient coughing during her lunch, which triggered an SLP consult for a swallow eval. The SLP completed the chart review and didn't see any red flags for dysphagia or aspiration pneumonia. When she entered the patient's room, the patient was independently walking around and asking when she would get to leave the hospital. She was on room air and didn't have a fever or other signs of an infection developing. The SLP completed the bedside swallow evaluation and didn't see any concerns for dysphagia. Even the patient didn't have complaints with her swallowing. So the SLP wrote up in her note and signed off on the patient, recommending no diet alterations or follow-up swallow evals unless change was observed. Sure enough, later that week, she developed a fever and required supplemental oxygen. Her chest x-rays showed concern for developing pneumonia. The team placed new orders for a swallow eval, and this time the SLP recommended a VFSS. When she completed the VFSS, she was shocked. The patient was grossly, silently aspirating thin liquids. Everyone was stumped as to why. The SLP returned to the patient's chart and dug back as far as she could possibly go. The patient had multiple hospital admissions over the decades, but this SLP had originally only reviewed the notes from the prior 2 hospital admissions along with the current admission notes. She finally found a note that listed a crucial piece of the patient's past medical history that for some reason didn't get carried over to the future notes. This patient had a history of laryngeal cancer 30 years prior and completed multiple rounds of radiation therapy to her neck. This piece of information was missed by the entire medical team for years. It gave us the explanation for her silent aspiration. By the time it was discovered, the patient was on a Venti mask for oxygen, and the team was monitoring her closely in case she needed to be intubated. Thankfully, she did not need to be intubated, but the entire focus of care switched to dysphagia management and preventative measures for future aspiration pneumonia. This is an excellent example of why we need to dig deep into patients' medical history and put on our detective hat at all times. Number 2, routinely check the evidence. It's not possible to always keep up with every single piece of new evidence that comes out, not only because it's a lot, but also because research papers aren't always freely accessible. However, just like any other clinical or medical profession, it's required to keep our knowledge and skills evolving and up to date as new evidence comes out. The way SLPs practiced 50 years ago has vastly changed compared to how we practice today. That's thanks to the evidence and keeping up with what's relevant to you and your work. But if it isn't possible to even access all of the evidence, how do you keep up with it? Thankfully, there are multiple communities and resources out there that support open discussions about the evidence. You can join an ASHA special interest group to receive weekly or daily emails with discussion threads on various topics or new research opportunities. Carve out time once or twice a month to watch a new webinar about a topic relevant to your practice. Attend state or national conferences and absorb hours worth of foundational and updated information. Start or join a journal club. Even just asking your friends and colleagues about their practice and the evidence they follow will help expose you to new ideas. There are several ways to find open access journal articles too. Check out doaj.org, which stands for the Directory of Open Access Journals, and search any topic. This is an independent index of peer-reviewed open access journals from around the world. Another option is to email the authors to request a free copy of an article you may have found online. You might be pleasantly surprised by how many authors are eager to give you free access to their paper. One of the best ways to make a routine out of evidence-based discussions is to join or create a journal club. This could be virtual, in person, outside of work hours, or even during work hours, if your department approves of this educational opportunity. One SLP I know shared an experience with me about a job she used to have where the SLP department held weekly journal club discussions during their lunch break. As a newer SLP, she found herself getting challenged by one particular colleague who had been practicing for over a decade. Recommendations made by several SLPs in this department appeared to be more fear-driven and conservative than needed to be, and my friend wondered if they had discussed any literature about the pillars of aspiration pneumonia yet. Apparently they hadn't, so she used this opportunity to suggest this topic, and it set the stage for a constructive discussion about the differing practice patterns. There was still resistance, but it allowed for ongoing discussions and even multiple journal club discussions about the impacts of aspirated thickener on the lungs, risk factors for aspiration pneumonia, and the risks and benefits of the Fraser-free water protocol. The entire department started to see a shift in how they practiced, and they challenged each other in a more supportive manner, giving these opportunities to learn about the literature together. I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Also, do you have any specific questions about chart reviews or keeping up with the evidence? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. And make sure to stick around to the end to claim a freebie or two. Number 3, use cognitive empathy and advocate. While it's important to think critically like a medical SLP, it's just as important to not stay in our own heads. We need to also understand what our interprofessional colleagues and our patients are thinking. This is where cognitive empathy comes in. Cognitive empathy is the ability to understand what others are thinking or experiencing. For example, we as SLPs might understand why it's important to get an instrumental swallow study before recommending thickened liquids or specific compensatory strategies, but our non-SLP colleagues may have been taught differently. They could be coming from a place of past experience, where prior SLPs practiced in a way that relied more on bedside swallow assessments. Or maybe they have heavy pressure coming from higher powers to discharge patients more efficiently. Or maybe they're so overworked and understaffed that it's not always possible to get in a VFSS before the patient discharges. And from a patient's perspective, maybe they know they aspirate and they're okay with it because it's more important to them to enjoy Sunday brunch with their family or sip on their favorite drink with friends. Harnessing the power of cognitive empathy can also strengthen your advocacy skills too. If you understand where your colleagues are coming from, you'll have a better idea of how to better advocate for your services or the services of others. Speak their language by learning the research. You want to advocate for AP view during modified barium swallow studies to a radiologist who is resistant. See what the radiologist research says about the AP view. You can also look up what different professionals' national organizations or governing bodies state in their practice guidelines. Understanding what other professionals are taught, what their demands are, and where their stressors come from can help us better understand how they think and how they feel. Garnering this type of understanding will help set you, the patient, and the team up for success when it comes to best practice. If you work with radiologists, there's a high likelihood that you've met resistance during the VFSS. Whether it's to do an esophageal sweep, AP view, 30 pulses per second, or even just to continue the study after the first aspiration event, cognitive empathy is a key component to building a bridge over this gap in practice patterns. One SLP inside the MedSLP Collective had been battling her radiologist for quite some time on pulse rate. Pulse rate is the number of radiation pulses per second. The higher the pulse rate, the more the radiation. This SLP was well aware of the research behind 30 pulses per second being the optimal pulse rate during VFSSs, and how this could lead to improved outcomes and possibly even less radiation exposure, particularly when a repeat VFSS isn't needed in an attempt to get a clearer view of the swallow. She received an email one day from the head of the radiology department. They wanted to set up a meeting with her to discuss VFSS guidelines. She knew they weren't in agreement, so she took the time to research the radiology publications as well as the American College of Radiology VFSS practice guidelines stated. This set her up to speak their language instead of just harping on SLP literature. Not only did she read their literature, but she printed out articles and highlighted lines that were in agreement with SLP literature for best practice. When she showed up to the meeting, research papers in hand, the radiologists were impressed. They had originally suggested that they only use 30 pulses per second during the initial swallow of a texture or liquid consistency, but then drop it down to 15 pulses per second for the subsequent swallows of the same texture or consistency. From their perspective, the number one rule with radiographic exams is ALARA, an acronym that stands for as low as reasonably achievable, meaning the radiation exposure. With her knowledge of both the radiology and SLP literature, she was prepared to share multiple perspectives. By the end of the meeting, everyone was in agreement to stick to 30 pulses per second throughout the entire study. I've got a free gift for you over at MedSLPcollective.com. You'll get instant access to our free MedSLP Collective clipboard kit. We have a robust and vibrant community of SLPs and mentors to help you out with your toughest clinical cases. Head over to MedSLPcollective.com now to get your hands on this. The link will be in the description below.